Thank you very much for your warm welcome. And it's quite a challenge to do that in as short as possible minutes, because I know that I am standing between this lecture and your tea. So I will try to keep it short, and but I think it's important just to go back 10 years ago, actually 12 years ago, because then that was the moment that I got involved with the bone and joint decade. And actually I was just becoming involved in patient advocacy work, and it was at the moment that Mika Hazes, she's one of the members of the International Steering Committee, approached me and asked, are you willing to join the Dutch steering group for the bone and joint decade? And what I remember from that meeting and the way that we worked from that on, that was actually two things. And the first thing was that I found it quite exceptional the way that I would be able to speak and to work together with the professor and to speak to her just with using her first name. And she was accepting me just as an equal partner, actually as a colleague, in a joint effort to raise the profile of arthritis in our country. So that was quite a new thing to find out, that you can work with professionals on a similar, equal basis without any differences. Not as a patient and a doctor, but just, that was the first thing. And the second thing that I remember was that we were struggling, and we spent hours together with our first group in determining the objectives of the decades. The objectives of the decades in our country. What do we want to achieve within 10 years? And we all made all kinds of plans, and we put a figure on it, and because we must be very smart, and we want to get the number of hip fractures down, and there were all the things. But the most important thing was, what we want to achieve was more collaboration between different organizations, like the physiotherapists, the surgeons, orthopedics, patient organizations, rehabilitation, etc. And I must say that was, in the first 5 years that I was involved, was very successful, I must say. So all these groups came together, started the dialogue, and has resulted in something good. We're talking about patient-centered care. I think one of the objectives was, of course, the overall objective, to higher the quality of life of the people for whom you are working. And I think that's harder to measure. And one of the presentations, I think it was the one from Tora, he mentioned quality of life in some of his studies, and he presented some data on improved quality of life over the last decade, but the figures were for, I think, for Norway only. But of course it's very interesting to know all the efforts in the last decade. Has it made the quality of life experienced by patients better? And what do we know about that? And it is of course striking that all what was presented today is a little bit in the light of this biological revolution. So a lot of investments are done in research, in drug research. But if we talk about patient-centered care, I must admit that there is a lack of data on effectiveness of non-pharmacological interventions. So it's very hard to say anything about effectiveness and the level of implementation of this. So I will not give a lot of evidence, although I have done in the last year a systematic literature review on patient-centered care. But there's something else that I want to present here, and that is just to show that the decade at least has shown that collective collaboration is beneficial for scientific research, developing guidelines, healthcare policies, and the education of professionals. But now the challenge is, are we also able to transform these successful collaborations into the consultation room, in the dialogue between the patients with the doctor. Because I think that is, in the end, also something that we should strive for. And I think that there are advantages that we should strive for. So the question is also, all these developments and progress made in the other fields, did they have an impact on the way that healthcare is provided? So I will go a little bit through these different areas, but just very shortly something about patient-centered care. First of all, there's not a consensus about a definition of what we should mean with patient-centered care. But there are a number of features that are commonly reported as being part of something that you could call patient-centered care. First of all, it assumes a holistic approach of health and well-being. So a holistic approach means that you should not only look at the physical aspects of the disease, but you should also look at the more social impact and consequences of the disease. A second thing has to do with communication. And of course, in the past, we all know that communication could be quite hierarchic, top-down, directive, while what we want is more develop equal structures with open communication, doctors that takes time for you, and that there is really a dialogue with patients about what are their preferences, what are their anxieties, what are they looking for, and what are they willing to do to manage their own disease, and where are their limitations. Within the rheumatology area, and that's where I know a little bit about, I know that there is quite an extensive amount of information on patient education and self-management programs. And I think this is something also very important to get patients involved in that dialogue, to learn them, to empower them, that they also see that they are responsible for their own treatment. And at last, I must say, of course, important is that there is also a role for other health professionals than their specialists. So that could be the family doctor, nurses, but also multidisciplinary team care. Just to start a little bit with what we learned from scientific research, and I will do this very short because Peter Brook this morning has introduced what OMERACT is. And I think one of the big things of OMERACT is that it has learned us how patients can be actively involved in research. Not only in particular part of it, but patients can play all roles, including data analysis, facilitating moderate sessions, give presentations, help in recruitment of respondents, etc. And I think specifically in OMERACT, they have shown that it's not a one-off, but since 2002, patients are a substantial part of this process, and they also have influenced the outcome. And I think that's very important. It's not just to be political correct, but it has added value. And I think twice the core set, the RA core set, for instance, was projected on the screen. But what was not on there is that in 2006 there was this official endorsement by OMERACT that fatigue as an criterion, which was quite important from the perspective of patients, is added to the core set as a recommendation, as something that should always be measured if you conduct a clinical trial. So I think that was, and if you look around and speak to people, that was really the that would never have happened if patients were not involved in OMERACT. Patients' involvement in developing guidelines. I think several times guidelines here are also introduced. And I think what we see nowadays, more and more guidelines are developed with direct and active involvement of patients in the development process, including also assessment of data,